Bonjour from Canada. It's an honor and a pleasure to be with you, even if it's virtual. Unfortunately, I cannot travel for a few weeks because of recent eye surgery. This is me an hour ago out in my backyard. We have 1 meter of snow on the ground. My conflict of interest statement includes activities on the editorial boards and member of scientific advisory boards. So the objectives for today were suggested by your organizers and include giving a perspective on the natural history of Alzheimer's disease, talking about stages and how to measure various symptoms over time, look at recent findings in biologic research, summarize risk and protective factors for dementia that are amenable to prevention, population-based approaches, and study examples of clinical practice guidelines that can be done by clinicians in a given country. My presentation is in 4 parts, and I have a brief summary after each part. It's natural history, findings in AD biologic research, and relevance to clinical practice, population-based prevention, protective and risk factors, and development of clinical practice guidelines. Natural history, as clinicians, the audience are aware, classically in Alzheimer's disease, there is a sometimes 3 to 5 years of non-specific mood and behavior changes that can be social withdrawal, anxiety, sometimes early warning of forgetfulness for things that are routine, looking for words. It's not quite enough to call it cognitive impairment, but there is a subtle mood and behavior change. We have a name for this now, and I'll get to that in a minute. Then there's the more classic linear cognitive decline, functional decline. And then in Alzheimer's disease, there is this phase of major behavioral disturbances that include nighttime agitation, not recognizing the house and the spouse, and can lead to physical aggression. Note that typically these individual behaviors do improve over time, and whatever interventions you need, reassess their need over time. And then if you live through the 6-7 years of these symptoms, there is this last stage of Parkinson-like rigidity, falls, difficulty swallowing, and you die of an aspiration pneumonia. Variations on the theme could be the cognitive symptoms are not so much memory, but looking for words, progressive aphasia, or difficulty with vision of a posterior cortical type. Behavior, usually in Alzheimer's, there is this milder mood, mostly change, and then later psychosis, agitation, nighttime disturbances. In dementia with Lewy bodies, you would have earlier major psychiatric symptoms such as visual hallucinations and false beliefs. In frontotemporal dementia, you would have mood, behavior, and sometimes psychotic changes before cognition is declined. If you have mixed dementia, Alzheimer with vascular features, you could have Parkinson motoric changes early on and falls, etc. So now we talk about minimal behavioral impairment, MBI, and there is a checklist that has been developed and it's being now translated in multiple languages. There is an opportunity for you to translate it in Arabic and add it to the list available worldwide. Then there is a more classic mild cognitive impairment stage where different measures are available. The MOCA is the most widely available, and it has been translated in Arabic and multiple languages. There is a 3 to 5 years of natural history before dementia is evident. Classic dementia involving at least two cognitive domains, not always memory, could be executive and vision, executive and judgment, and it varies. But it has to interfere significantly with daily life. And there's a gray zone here based on gender and where you are in your work life, retirement life. Mild to moderate is usually 3 years, whatever you do for treatment. And then when you get into moderate dementia, you need more assistance for daily life. You cannot live alone all the time. Um, Behaviors start to emerge, especially at night, and the severe stage. And depending where you live in the world, you probably don't live alone at home. You need full-time assistance, or you move to a facility with full-time support. Usually, you will die of motor kind of complications, such as aspiration pneumonia. Now, you see the symptoms change over time, over a span of 8 years, and the measurements done for research as well as clinical practice do change. The extremes are for cognition. The MoCA, Montreal Cognitive Assessment, is good for MCI and early dementia. But if you go to moderate to severe dementia, you need the SIB, Severe Impairment Battery. For behavior, now you have the option of the Minimal Behavioral Impairment Checklist, which is good for minimally symptomatic people, MCI. And the Neuropsychiatric Inventory, NPI, 12 items, is for the mild to severe dementia. I just want to bring your attention to the global assessment, which is something we do clinically when we assess somebody on follow-up. Is he the same, better, or worse, based on an interview with the family and the patient. This can be structured, such as the Clinical Global Impression of Change. And there's an instrument called the Clinical Dementia Rating, CDR, which was developed mostly for the MCI early dementia stage. But it is now a major instrument in clinical trials, and we may need to use this for treatment with the new generation of medications that I'll talk about. Of note is the CDR sum of boxes. So it's worth spending a minute to explain what it is, because it is relevant to our discussion about the clinical utility of the new drugs. So the CDR is a semi-structured questionnaire. It's done first with the accompanying person, usually a family member, and the person with symptoms. It could be MCI or mild dementia. There are 6 domains being asked about: memory, orientation, judgment, and problem solving. That's 3 cognitive domains. And 3 functional domains, that is community affairs, home and hobbies, personal care. Each item is scored 0 to 3. So the maximum score would be 3 times 6, 18. If you add it up, sum of boxes, you get a total of 4.5 out of 18 when you have mild dementia. The progression for 1 year would be in the order of 0.5 to 1.4. The best results so far with the best drug available, lecanemab, is a difference of 0.45 after 18 months. So here is the result that was published in the New England Journal late last year. After 18 months of treatment with infusions IV twice a month, you see that the delta, the difference for the CDR sum of boxes, a semi-structured global score, is 0.45, which is roughly equivalent to 1 year of difference. Okay, so the debate is this meaningful? So just to summarize this first part about natural history, you have a typical pattern of symptoms, at least for classic Alzheimer's disease, between ages of 65 to 90. The intensity of the different types of symptoms do change over time, and the measurement scales need to be adapted to each stage, if you do a clinical trial or in your clinical practice. There is variation in the speed of progression from one stage to the next. So if you're on mild dementia stage, usually you're stable for 3 years, whatever you do. If it's very fast decline, you would be called a rapid decliner. And this would trigger a search for associated or concurrent illness, stroke, some additional factor. Once you're in the moderate stage, usually it's a steeper decline cognitively and functionally, and there are emerging behaviors that usually mean you leave home, and then things evolve faster. There may be a plateau in the severe stage, depending on your general health. Next topic is findings in AD biologic research in the recent years. So the big one is the ATN biologic definition of Alzheimer's disease, A for amyloid, T for tau, N for neurodegeneration. And you can see that various tools are available, some more complex or expensive than others. PET imaging, MRI, spinal fluid examination, and now blood. To be practical, these are different persons in a cohort followed at McGill University. Some have no symptoms, some have minimal symptoms, some have mild dementia. On the top is the amyloid scan. In the middle is the tau scan. And the bottom shows the glucose FDG scan, which is an indicator of neurodegeneration. I just want to draw your attention to the middle one. The resolution, spatial resolution of the tau pathology is so fine that you can see in the middle very little pathology, BRCA1 or 2 pathologically, in someone with no symptom. And then if you move right, other persons with minimal symptoms have spreading of the tau pathology in other parts. So there's a way to quantify in vivo using PET imaging the spread of tau pathology, and new clinical trials will take advantage of that technique. If you can stop progression from BRCA3 to 5, that would be very meaningful, biologically speaking. Surprise, sometimes we have a candidate for these studies who has Alzheimer's clinically, but there's no amyloid in their brain. This is an example. 80-year-old man, mild dementia, looks like Alzheimer's. There's no amyloid in his brain, as you can see in the top scan. But the middle scan shows a lot of tau pathology. He's already at BRCA5 on a scale of 6. And the bottom MRI shows a widening of the hippocampi, a fissure, as in Alzheimer's, and very little vascular changes. So we're not sure what he has. We call it now tau predominant dementia. And that kind of person is a bit of an orphan right now. There's no specific drug trial for these people right now. It may progress over time into a progressive supranuclear palsy kind of syndrome. I've seen that before. Now, the blood biomarkers is the big novelty of the past year. You see on the left one of the many published studies demonstrating that p-tau isoforms, fragments of phospho-tau, this one is 217, in the blood, in blue, in the red box, is very high relative to all the other controls and other kinds of dementia. There's a debate about whether 217 is better than others for very early diagnosis, and maybe some others would be indicators of response to treatment using amyloid-specific drugs. But these biomarkers are likely to stay for early diagnosis, who to refer to a specialized clinic, and how to monitor response to treatment. A bit like PSA for prostate cancer. On the right, you see a recent version of the classic curves that show that before you have any cognitive decline and functional impairment, there's a sequence of amyloid change, low levels in spinal fluid and blood, then amyloid PET scan change, and then you have spinal fluid and blood tau changes, and then you have tau pathology, although, as I illustrated, the resolution, the spatial resolution of the new tau imaging is so spectacular that we can really say someone has BRCA2, 3, 4, 5. And then you have clinical symptoms. So there is a 5 to 10 year window of opportunity for treating someone who may have, biologically speaking, Alzheimer's before they get symptoms. So the classic teaching we have about Alzheimer's is there's a sequence of pathological events over 20 years or more. The early changes are beta amyloid deposition in the parenchyma. The oligomers float around and they coalesce into those plaques. Some people worry that if we break the plaques with immunotherapy, we could cause more harm than good, but that's still a debate. There is microglial activation or neuroinflammation at some stage. It may vary between individuals and the timing before you have significant tau pathology, which is mostly intraneuronal, but there is spreading of the neurofibrillary tangles through synapses in a anatomically known way between regions. This is reflected then in neuronal loss or atrophy, and then you have symptoms. In terms of treatment, our hope way back 30 years ago was that once we have a diagnosis of mild dementia due to Alzheimer's, we would have this line D, arrest of progression. And we'll see what the curves actually look like when we have the first anti-amyloid therapy used alone. Immunotherapy is the mainstay of anti-amyloid therapies. It's worth noting that we've tried over the past 12 years secretase inhibitors, fibrinogenesis modulators, and there have been a lot of attempts to modify the amyloid deposition and increase clearance. And so for immunotherapy that is passive, the antibodies are given intravenously or subcutaneously, has been the most successful. The lecanemab, I mentioned already, you see the top graph we've looked at before. It's the 0.45 delta after a year and a half of treatment on the CDR sum of boxes. Allow me to contrast this with the middle left panel. This is the amyloid change, huge drop in amyloid level in the brain for the group as a whole. No doubt that the antibodies cleared the amyloid out of the brain. But the clinical impact with amyloid monotherapy is small. So to summarize this part, the new biologic definition of AD it does facilitate research, but it's currently limited to two proteins, amyloid and tau. We need to amplify this to include vascular factors that may be very important in some populations, especially in Asia. Neuroinflammation, which may be silent and very important sometime between -10 and -5 years. Alpha-synuclein, which is reflected sometimes clinically into a mixed Alzheimer and Lewy body dementia pattern, and TDP-43, which is the main protein, perhaps over age 90, that we need to target. Blood biomarkers are coming, and I think they will be useful for research and clinical practice. And I mentioned already the discrepancy in effect size between the improvement of amyloid levels and the clinical benefit. Now, population-based prevention, this is a popular topic. Every so often we get these Lancet commissions. This is the 2021, the list of items that are known to be relevant to risk of dementia are now 12. You see the list in the middle. There are new ones, air pollution, that was a surprise, but it does stand out in the recent epidemiologic studies. Traumatic brain injury, no surprise, it is there, although it does cause a different kind of tauopathy than classic Alzheimer. Hearing loss is important. Most people we see in our clinical practice over age 80 have hearing impairment, and it is clearly an accelerating factor in cognitive decline, so it should be checked for and treated. Notice on the bottom right, novel risk factors still being evaluated, and some of them are important. Sleep deprivation and chronic gum infections. They may also be modifiable factors. Now, 12 items is a lot to deal with as clinicians, so I selected two recent publications from last week. This one is from the Framingham study, where they looked at specific risk factors that are modifiable. And no surprise, they find that in a population in North America, the order of 4,000 people, diabetes has a hazard ratio of 1.6, physical inactivity 1.6, and obesity 1.76. And for that particular North American population, these are the obvious factors that need to be modified. And the point they make is if you have all three, you're more likely to get dementia. So no surprise, but for that particular population, these are the factors to treat. Quite a different country, China. This is a large study, close to 30,000 people were followed over 10 years, age 60 and over. The mean age is 72. And the authors looked at what happens over time in your memory using a reliable test, auditory verbal learning test, for those who have 4 or more of the following 6 healthy habits. Healthy diet for Chinese, regular physical exercise, active social contacts, no smoking, no alcohol. And they compared people with 1 or 2 or no healthy habit versus 3 or 4, and then those above 4. And there is an obvious effect, as you will see in a second. the good news is that even those who are at genetic risks, that is APOE4 genotype carriers, they also get benefit from the combination of healthy habits. So these are an example from the article. You have in blue, the middle, those who have 3 or so of these healthy habits. Green is those who have 4 or more of the healthy habits, so their decline in memory over 10 years is much lower. And in red, those who have not many healthy habits, they get worse. And it's the same for the APOE4 carriers. So that's an encouragement for those who may have a family history or may know they have an APOE4 genotype. Now, these are observational studies. Now there are intervention studies taking advantage of the knowledge about preventive and risk factors. The classic one is called FINGER. It was done in Finland. It involved quite a large number of healthy middle life, late life individuals who are randomized to a combination, that's important, a combination of nutrition, exercise, cognitive training, social activities, and vascular risk monitoring versus usual care. And after 2 years, there's a big difference, but surprisingly, it's not so much memory, where there is a difference, but it is in executive function and processing speed. And that may translate into maintaining more of your instrumental activities of daily living, the ability to make decisions, to plan your outings, etc. So this was a first and very encouraging trial, and this is being now copied worldwide. Every country or block of countries is trying to reproduce this, fine-tuning the package of exercise for the mind and the body, and combining this with sometimes a food supplement. But this is another important stream of research that will have implication for the populations as a whole. So to summarize, population-based prevention is currently the most realistic way to decrease dementia prevalence worldwide. But in addition, we can pursue a personalized approach based on genetic APOE4 and biological risks. So small strokes that you can detect, history of heart attacks. You may have to have active interventions for the vascular risk in addition to the lifestyle changes. And Alzheimer may become more of a chronic condition, such as diabetes, where you have pre-symptomatic pathology that is detected through blood tests. And then you have early symptoms, which is polyuria, comparable to the MCI. And then you have organ failure. So finally, development of clinical practice guidelines. So the big one was the World Alzheimer Reports, 2021 about diagnosis, 2022 management after diagnosis. These are documents that are available online. Just go to alz.org, I think it is, or ADI, and look up the ADI webpage. Some examples of what came out of the surveys among clinicians, among patients and their family members. Invited essays involving over 200 people. For the diagnosis work group, the report, do you have healthcare systems must make culturally appropriate, translated, and validated cognitive assessment tools. So, for instance, if you need an Arabic version of MBIC, do the translation, and Dr. Ismail will help validate the translation, and then it's put on the web so all Arabic countries can take advantage of it. The other big message is how to disclose results to people and their families. Most clinicians who answer the surveys are not shy about exchanging information unless there is a risk of catastrophic reaction. And the information has to be given in a clear way. One thing I feel strongly about it, and you need to also be truthful that you may not know the cause of the dementia currently, but time will tell in some cases. And the other report, which is management, has a lot for clinicians. And I encourage you to look at chapter 6, which is for primary care setting, the 17 for how to best use the currently available symptomatic drugs for dementia. 18 is how to use the upcoming disease-modifying drugs. And my favorite chapter is 19, which is special care needs for people with specific kinds of dementia. So if you're younger than 65, if you're over 90, if you have Parkinson's disease dementia, if you have PSP. So each major group of dementia has its own management package. Now, can we translate this into clinical practice guidelines for our own country? So I'll give you two examples. One in Canada is multidisciplinary. So for the past 30 years, every 5 years or so, we meet and we have family practice, neurology, psychiatry, geriatric medicine, sometimes nursing coming together. It takes a year to plan. You review the evidence and then you get some proposal for clinical practice guidelines and we vote on them, and then we meet face to face once to sort out those who are not quite reaching consensus. And this is the last one where we were very ambitious in terms of numbers of items to discuss, but there you go. I just highlight the fact that neuroimaging, for instance, we do have guidelines for who in Canada needs a glucose scan and even an amyloid scan. We do have these scans available for selected individuals covered by the state. Non-cognitive markers of dementia, that's hearing impairment and walking, gait impairment could be an early feature. And not just because of hydrocephalus or multiple strokes. Gait impairment seems to be a feature of dementia at large. And finally, we did discuss the prescription of anti-dementia drugs. There is sometimes a need to indeed stop donepezil-like drugs when the condition has progressed. Another type of guideline is in the US, Dr. Cummings and his group addressing how to use aducanumab when it was approved, although not used, but lecanemab is going to be approved and used. So what can we tell the clinicians? Who can use this kind of drug? What kind of training will be required to need the MRI? So somebody takes the lead. It is clinician-oriented. So that's what I would encourage you to do in your own country. If you have a need for guidelines, just get together, look at the evidence, publish it, and share it. Because the scope of what we do now is very broad. As clinicians in the field of cognition, you may see people at risk, just worried well, and then you would make them aware of preventative factors. And then you may have someone at the MCI stage who up to now had no specific drug treatment, but now there may be one, there'll be others. Antidepressants and cholinesterase inhibitors are often used in the mild dementia stage, but there is now also the option of an anti-amyloid therapy. And in moderate stage, we have memantine, and moderate to severe, you may need atypical neuroleptics in low doses for periods of 3 to 6 months. And then when people reach a severe stage of dementia, we have to deprescribe progressively. So to conclude, care for persons living with dementia and their carers need to be appropriate for each stage of disease, ideally with the same clinical team and an anchor person or navigator, a bit like what we do for cancer and diabetes already. So Alzheimer would become a chronic illness that requires chronic management. Biomarkers, particularly in the blood, may offer a personalized biological diagnosis in persons with cognitive decline. So this may be very relevant for younger people, 60 to 75, who want to have a biologic diagnosis and perhaps an early treatment. A combination of protective factors may delay onset of symptoms at the population level. And the finger-like studies that are underway around the world need also our attention. And we do have an opportunity as clinicians to update best practice guidelines for the diagnosis and management of our patients. Thank you for your attention. Enjoy the meeting.